also said we're not going to give you as much money as we promised you at first because the program has not been funded by Congress as we thought it should be. And so they not only changed the rules after we got into it and agreed to it, but that just shows you what has happened already as the government has become more entangled with medical care and what's going to get even worse as time goes by.
Well, and Dr. Scioli, I know that you talked last time about how you on I guess, case-by-case basis will sometimes make determinations that, in a sense, you donate some of your time, saying that, maybe you get it on the back end, but there's some people that you look at and you say it's just the right thing to do to provide care. But then the issue is how well do we, if we say, okay, we're going to leave this to the medical community to provide the care, we're going to keep the government out of it, but I wonder, would there be a rise in support for that, or in some ways do we need something to help bring people out to help, or
right.
I don't know if I have a good answer, but what
I understand exactly what you're asking, and here's the thing. I'm an investor at John Surgery Center. It's still difficult to bring patients, although we bring indigent patients all the time. I've brought indigent patients who are denied entry to both Covenant and UMC without putting up a bunch of money up front. And I've done that patient at North Star. And we either eat it or they pay what they can pay, but at least I was able to give them some care there. The public wouldn't necessarily know things like that take place, but they do. The frustrating thing about donating care or service, I can donate the whole thing, but the facility would have a justified request that the vendor donate their supply, the anesthesiologist donate his time, I would donate my time, and everybody coordinate. So that's a lot of work to do. And we, I think, need to go that direction for the most indigent amongst us. Now, in theory, with these new health reforms, there would be coverage for certain things. But au contraire, you got to remember, if you have certain type of coverage, be it Medicare, for instance, I can't do certain implants at an outpatient facility, even though it's an outpatient case. I have to do that specific case, say a thumb implant on a Medicare-age patient, as an outpatient at the hospital. Why is that? Are they trying to save money or not? It's no different in terms of safety. In fact, it's much more efficacious and probably, I can prove to you, a less infection rate, more efficient, easier on the patient in and out to do such cases at a surgery center, but they're not allowed to be done there by the government. And then you see things that say, oh, the doctors cherry pick their cases if they're investors in facilities. You want to bet? I would take every case. Medicaid, Medicare, everything. I'm not allowed to. We don't cherry pick. They cherry pick. It's amazing. They say, oh, you bring all your Medicaid over here. That's because Medicaid says I'm not allowed to do that kind of a wrist replacement in my service center, even though I would love to do it. Well, all of a sudden, you're looking at restrictions put upon us by another entity, and they're all screaming, we're not saving enough money. And I can tell you, I can save you money by letting you do that case in my service center, and they say no.
Well, but, John, as I've talked over the years with various physicians associated with North Star, that there's all this political maneuvering about when freestanding surgery centers came about in the last decade or so, that it seemed like there was things happening in Austin, things happening up in Washington that were reflective of market forces that said, we don't care if you're cheaper, we don't want the competition. And so they actually, it seems like the laws weren't really about the interest of the patient, they were about protecting the interest of some of the corporate whether they be
The big
larger
hospitals.
facilities, hospitals or things. I mean, I'm sure you've been through some of that battle.
It's not an Austin thing, it's a
Okay.
Lubbock thing.
Okay.
Make no mistake about it. And what he is describing there is rewarding the hospitals for their incompetency and their inefficiency. They pay a higher outpatient rate to hospitals than they do to ASCs because they feel like they deserve it, because their costs are higher. And my question would be, what are they doing to control their costs? Now, the thing you're describing in Lubbock, and I don't know if we really want to go here on this particular in this particular venue, but the thing you're describing is a Lubbock issue. You look at Blue Cross and Blue Shield of Texas, will not allow us to do total knee replacements, or basically we cannot do total knee replacements because we can't even cover the cost of the implants on their Texas ASC fee schedule. But I've got 3 orthopods at least that would like to do them there on obviously non-Medicare patients, the type of patients that could come in, have that total knee, stay 23 hours. The savings to Blue Cross is monumental. North Star has done over 40 of those procedures between 2001 and 2005, all successfully. Blue Cross of Texas will not manipulate their fee schedule to allow them to be done in an outpatient setting at a savings to them because of the political climate in Lubbock.
And is that, Dr. Hartman, for having worked inside of Blue Cross Blue Shield, are there these forces that are out there that make it difficult to keep a focus on the patient?
Well, yes, there are. Actually, one of the things that surprised me was to find out that the hospitals in Lubbock, for most of the inpatient care, particularly in reference particularly to cardiac surgery, the hospitals were receiving a higher pay per day than the hospitals in Houston for similar care. And Blue Cross was trying to get out from under it, but somehow they never could seem to get out from under that. Every time they negotiated, about every 3 years, it ended up that they were paying more for Lubbock than they were for Houston.
Well, and I think that's the fear, and you know, in some ways I think I'm probably a little bit more left-wing than most of the people at this table, but I have that distrust of government in the sense of it's not even so much a government as it is the money that exists in our society that attaches itself to forces in our government that then act as if, you know, this is about the government, but is it the government, or is it, you know, is durable medical equipment people, do they have a good lobby that's protecting them? When we talk about the AMA, what's their interest, the AARP, and so, again, I go back to the point that my father made, which is this really about the best interest of the patient? And it kind of gets lost in there. Either we're just saying this is about money, but it's not even about money. It's about who's got the best power to direct who gets what, even at the local level, and how much people really understand that.
And were they receiving better care in Lubbock? I don't think so. I think they were receiving as good a care as Houston, but I don't think it was better, but it cost more. And I never could understand that.
Well, but that's what I'm saying about, but if you follow the money, you know, is this about the money that local hospitals maybe were able to go in and say to some of our elected leadership, here's $25,000 for your election campaign, and did that leader say, I feel your pain?
I don't know.
Oh, yeah.
I mean, there are a lot of things that figure into the equation. You know, you might have somebody who's in an elected seat in Austin who is contractually obligated to a local health system. You know, perhaps their law firm represents a local health system. Those kinds of things are difficult to overcome, and